Hello, everyone. Welcome to the first session today, AI Innovations Addressing Real Radiology Challenges. My name is Raza Mushtaq. I'm a neuroradiologist at the Barrow Neurological Institute, where I also serve as the Director of Head and Neck Imaging and the Associate Program Director of Neuroradiology Fellowship. Today, I'll be talking about challenging in radiology workflow and how AI can actually address those challenging. This has become a very timely discussion. I think radiology is at an inflection point where volume and complexity just keeps going up and up, but our time and cognitive bandwidth hasn't really caught up to it. So today is really about practical AI, tools that can reduce friction and improve care. And it's not just tech demos, which you'll see a lot during our SNA this week. I work across a high volume multi-hospital environment where we really value speed and reliability. We're always looking to help improve our workflow to make it more efficient, and I think that's really the crux of what AI is about today. How can we use AI? How can we leverage AI to make our workflows more productive and more reliable? As such, my research has been very much focused on AI, and it's more translational AI research, which really means my focus isn't can it work, but rather does it integrate, does it scale, and do people actually adopt AI tools? That has been a struggle for us. We have multiple PAC systems. We have multiple AI softwares that we have, and integrating them all into one package has been really difficult. So that means I have like 5 different logins for 5 different things, so I have to remember like 5 different passwords. If I try to set the same password, IT tells me not, stop doing that. So sure you guys are aware of that. So those are some of the challenges we're really trying to deal with nowadays. In But to really talk about AI realistically, we really have to zoom out. Radiology is really an end-to-end workflow, and it's not just an interpretation based bottleneck. So right now, I think a lot of people are focused on how can we improve radiology workflow by dealing with the radiology read bottleneck. But the reality is that the system is burdened way before radiology even receives a scan. And even once you have generated the report for the scan, there's a lot of extra steps that really results in a lot of cognitive burden associated with it. So if you were to address, I'm sure like you see a lot of different things that goes into the radiology workflow, and if a lot of these you were try to target each one, you result in multiple different vendors, and that is not really functional anymore. I've had several discussions with our local imaging IT, our hospital IT, our corporate IT. We're part of Common Spirit, which is 150 hospitals. So I've sat into those meetings, and the discussion always has been how do we integrate AI and not keep proliferating by using multiple vendors. So each time you bring a new vendor on, they have to go through the security IT system, and that can take time. Like we had one product, it took us 2.5 years just to bring it online. We signed the contract literally 2.5 years ago, and it's just coming online now. And that's just because of all the security and everything that has to go with it. So it's almost better to have where you can integrate AI into one challenge, into one solution for all of these different workflow challenges. And we'll kind of talk about that as we go through why that really matters. And really, the core framework for the talk is cognitive burden, which we define as mental energy that is required to get from images to an actionable answer. So, radiology is not just interpretation, it's constant decision making while managing interruptions, which I'm sure guys know about. All the calls you get, prioritizing, making sure you document everything properly, follow up. And a lot of that results in a significant cognitive burden, which honestly is unnecessary. And that burden has continued to increase mainly through two ways. First is complexity. You have really hard cases with lots of moving parts. And second is repetition and volume, where you have many similar studies where you scan for rare positives. So the examples being your CTAs and multi-trauma CT exams. One of my fellows at the beginning of this year, when he was on his vascular rotation, told me that after the 20th CTA he read at the 10 a.m. mark, he was like, I don't know if I looked at the right vertebral artery on this scan or not. So it really starts to blend in once you're going through that many scans a day. just repetitive work, and that's where you start to have errors. And as you get this error, that burden increases, and that's really the goal: is how can we reduce this cognitive burden on radiologists, and that can result in better coordination decisions, which means faster turnaround time, and there's higher throughput and less burnout. So to keep this, so these are some of the tedious tasks that we perform. And to really study this cognitive burden and how that impacts radiologists, we surveyed 40 radiologists that had different backgrounds, different expertise, and we really asked them about different tasks and how each task resulted in cognitive burden and how a tool may help solve that. So as we go through, I'll show you the results of the survey and what we found. So, one of the biggest solutions that we want to talk about is Rapid Enterprise. In 2018, Rapid was exclusively a neuro AI company, but today it's much more than that. As we'll discuss today, Rapid AI has become part of over 2,500 hospitals. They are part of 75% of the comprehensive U.S. centers, and they have really contributed significantly to the growing literature with over 700 publications. And that has really been a game changer. We have had publications from Rapid that have resulted in guideline changes on stroke management. And so that's really how you grow in a clinical setting. So, um, Rapid has really focused on two main goals when they have kind of grown and how they wanted to grow. The first one was to provide automation of repetitive and tedious tasks through integrating very seamlessly into hospital infrastructure. And then secondly is to provide AI that drives meaningful insight beyond basic triage. So we'll start with talking about the administrative automation side first. So the first thing I want to talk about is the Rapid Navigator Pro. This is one of my favorite things. It really helps integrate everything into one clinical system. So when I'm interacting with Rapid from a PACS workstation, it's through the Navigator Pro, while my patient-facing colleagues are using this on their mobile app. So it is really very robust. So you have access on your PAC system and also on your app on your cell phone. So Navigator Pro does three things, and we'll talk each one in depth. The first one, it is provide a worklist prioritization. Second is that it reviews AI results and measurements, which they send directly to the PACS, or it's in the Navigator Pro itself. And lastly, it can actually pre-populate RAD reports with findings and measurements that can save quite a bit of time. So starting with the first is AI worklist prioritization. So I think worklist prioritization is going to increasingly become more of a challenge as the volumes grow. We have looked at how our volumes have grown over the last few years, and every single year we grow 5 to 10% in our volume. So volumes are going to keep going up. We're going to keep adding scanners, which means there's going to be more exams hitting the list. So when that happens, that's where you really run into issues. So what happens if you have 40 cases on your list and number 35 has a hemorrhage on it, and it's not a stat exam, and so you get to it pretty late? This may seem hypothetical, but this really happened to us recently. So when we are on call, we run quite lean. We have one fellow and one attending. And we recently had a case where the one of the very last cases, it was a non-stat inpatient exam that had a lot of hemorrhage on it, which was new from prior exam. So we didn't get to it almost for 2 hours later after the scan was done. So by the time we got to it, it had been a long time and the patient was on anticoagulation. So that's really where you run into issues. So having that worklist prioritization that automatically puts up the most relevant exam on the top is really what is a tool that is needed. And since that case, we have been very proactively making sure that we are engaging on this sort of solution in our workflow. So the solution that the Rapid provides is an AI triage, which is integrated into any worklist, and it prioritizes cases based on suspected findings. So you can see the red are going to be the findings that have suspected LVO or hemorrhage that gets bumped to the top of the list. So you're not getting to it later down the road, and you're really getting to the critical cases faster. And that faster turnaround time is exactly what you want. You want a solution that's going to result in improved patient care, and that's exactly the tool that results in that. So in our survey, we asked a radiologist, and they said that it was approximately on scale of 1 to 10. They thought that when they had to prioritize their list on their own, that it was resulting in a score of 5 on their cognitive burden. But a solution where they don't have to think about this would result in a 50% reduction in their day-to-day workflow, so where they don't have to think about this. So here's a paradox though. Even when AI is good, reviewing AI outputs can add work if it's not embedded in a workflow. So what that ends up doing is, even if you get AI, you're not going to get adaptability because it's going to be creating more problems for you. So a few things that causes that to happen. The first one is it creates new logins. Just like I was saying before, like if you have to log into a separate application, now you have to create a different password for it. And as you're doing that, you're sitting there waiting for the study to populate into this new software and get it processed. And that processing delays really contributes to breaking your momentum. So by the time you have pulled up the study in a second software, it's like 3 minutes, and you could have read a whole study in 3 minutes. So that is really not helping radiology workflow, but it's really hindering radiology workflow. So switching back and forth out of the PAC system is really not a practical way to do things anymore, especially when you have the ability to integrate into the PAC system directly. And when we asked our radiologist the same question, they said that switching between these different applications was scored a 7 of cognitive burden. So that is something that radiologists are thinking about, and it is creating an issue for them in their day-to-day workflow. Another thing that we have really talked about is having false positives entering the record. So what I mean by that is, let's say we do a study where we're trying to assess for progression. It could be progression of a demyelinating process or tumor. And I look at the scan, I compare the different flares, and I'm like, oh yeah, there's a differences in technique, but it's essentially unchanged. So I call it unchanged, but the AI output said it has progressed. So now there's conflicting reports in the patient's chart where we're saying, oh yeah, the radiologist said it's stable, AI said it has progressed. And with the patients having access to their records so readily now, that is what creates issues. So we have definitely had calls before where they have said, hey, you said the radiologist said this is stable, but this report is saying that it is not stable, that this is progressing. So that really does create an issue. So if you're able to have control on what sorts of output actually enters the patient record, that's honestly a huge plus. And that's something we have been working on quite extensively as we adapt several new different AI applications. So that's where Navigator Pro comes in. It overcomes a lot of the solution problems that I just discussed. So it's not a separate application that you have to log into, but rather it's embedded within the PACS system. So the goal should be simple. AI should not pull you out of the PACS system. It should meet where you already read. And that's exactly what Navigator Pro does. It's a PACS-based assistant and not a separate workflow. What makes it really cool is that it's PACS agnostic, so it integrates with all sorts of PACS systems. So any kind of PACS that you have, it will work with it. So the way it works is it can launch in PACS via hanging protocol, and you can just minimize it when you're not needing it. And it also has the ability to let you control results. Like if you want the AI output to go into the patient record, you can actually send it. If you do not want that output to go into patient records, you just hold off to it and you just review it. So how does this work in actual practice? So here's a case. So we're in our PACS environment. We're looking at a stroke case. We're looking at a CTA head and non-contrast CT. And the question is, do we suspect there's an LVO? And on the bottom left hand of the screen, you can see where the Navigator Pro is hanging out. So that it loads up and it just hangs out in the bottom. So it's not obstructing your actual tax workflow. It's just there in the background. So you click on it and it shows the patient and shows all the different algorithms that ran on it. So it says the number 9 here. So that's 9 algorithms that ran on this particular patient. So you click on that and then you see what algorithms ran on this. So in this one, because it was a stroke study, we cared about an LVO, large vessel occlusion, and it's suspected that on the non-contrast CT and also on the CTA. So once I see, oh, there's a large vessel occlusion suspected, I click on it, and this is what it shows. It shows you the heat map of where it thinks the actual occlusion is. And this kind of workflow is extremely, extremely helpful because stroke is always about time. So time is money in stroke. So if you get to the answer quicker, that means you get to tell the neuro IR quicker, which means a patient gets to the neuro IR suite that much faster. And that's exactly what this helps you do. So once you have identified that there is a large vessel occlusion here, then the next thing I want to know is there a penumbra? So I go back to my modules, I click on CTP, and so CTP is my CT perfusion, and my CT perfusion maps come up. So I look at the maps and I see, okay, there is definitely a penumbra there. I do my QC check, get my penumbra value, and if I think everything looks good, then I click on this on the top bar of it. There is an upload button, and that upload button will push the whole perfusion images to the patient's record into the PACS and goes into the EMR. So now you have controlled what outputs actually go into patient's record or not as well. You got into the answer much quicker, which means you get to the patient, to the neoangio suite much better, much faster. So the very helpful tool, we saw that in our survey, there was almost over 60% reduction in how this tool will decrease cognitive burden. So Navigator Pro, again, it's PACS agnostic. It integrates into PACS very easily, which means fewer separate logins, fewer external apps, and results can be reviewed where you already are. So you don't have to get in and out of different systems. So if you're reading pretty fast already, this will just make you that much faster. So the next workflow pain point we want to discuss is measurements. I think this is something that most of us have dealt with a lot. The measurement itself is really straightforward, right? You just take a calipers, you draw your calipers, you get your measurement. But the real time sync happens when you have to transcribe it. You dictate the numbers, you have to double check that the numbers are right, the formatting is right, and you can still mess it up. I have definitely messed up my centimeters with my millimeters before. As a neurosurgeon, once pointed out to me that a 4 centimeter aneurysm is much different than a 4 millimeter one, and I said yes, yes, definitely it is. But those kind of transcription errors are really, while they're small errors, they still contribute. They're still quite clinically significant, right? Just like 4 centimeter aneurysm and 4 millimeter aneurysm, much different in what you're going to do about those. So it's those repetitive tasks where you have to like double check your transcription errors that really kind of adds up across all the different studies and results in cognitive burden. And that's exactly what we found in our survey, that a lot of the radiologists felt that was a big pain point that needs to be directed. So this is where automated report generation helps. This is not writing the whole report for you, but it's pre-populating the structured part. So you do the measurement gets imported into your dictation software, whether that is PowerScribe or whatever dictation software you use. It gets automatically integrated into it, and that gets integrated into the impression part of it. So you're really taking out this error prone step out of your workflow where you don't have to worry about that anymore. Where so you can really focus on the interpretation and the decision making and not worry about things like this. Um, we found that radiologists said that this would be a substantial help in their workflow, going the cognitive burden from 7.1 to 2.7. Uh, Next pain point, I think, is the provider follow-up communication. If you're a radiologist, I'm sure you guys have thought about this. I took an academic job, so I don't have to call the providers. I just tell the residents. That was a huge decision-making point in which way I wanted to go after I graduated fellowship. And I think about that all the time. And I have to make a call. I'm like, hey, can you call them? And then I just walk out of the room, and then the residents generally taking care of it. But really, it's still a very big pain point. Because nothing says efficient modern healthcare like spending 10 minutes just trying to figure out who the ordering provider is, try to call them 3 times just to get their voicemail. Really an unnecessary burden that is there. And as a result, like in our survey, everybody thought that was one of the biggest pain points in radiology workflow that can be addressed by AI. And the problem isn't just the time it takes to get to the provider, but it's also about getting them in a timely fashion. So if you have a critical finding that really needs actionable, like something needs to happen, that's where this really comes into play. So in the example I discussed earlier, where let's say you had a hemorrhage case and you don't get to the hemorrhage case in 2 hours. And imagine like if you got to it 2 hours later, and now you have to spend like 20 minutes tracking down whoever is taking care of the patient. So that's just keeps at that time keeps accumulating, and that is what results in bad patient care. So something that's a big pain point for radiologists. So the solution is you should have a secure, case-based messaging that's tied directly to the images. So I'm in the study, I can see who ordered it, and I can click on the name and be able to text them like, "Hey, there's this finding," and then they recognize that they will say, "Thank you for letting us know." There's a closed loop communication, and then you're done with that case and you can move on. So the goal is simple: make it easy to message, and the coordinate next steps, and document that the loop was closed. And that is really how you reduce interruptions and you improve the radiology workflow. And that's what Rapid provides. So they have this the phone app. So if like the providers on the phone app, you can message them. You're even able to call them on the app too. So you're not hunting down what's the pager number, where they are. So that does it all for you. Um, what it takes, one of the things that takes it even further is this consult layer. So this is where you can actually interactively review cases across the team care. So you're kind of meeting the clinician wherever they are. So if they are in the cafeteria eating lunch, you can still call them on it, and you can share your screen and you can show them, oh yeah, hey, this is the finding. So that kind of consultation, which in pre-COVID era used to happen in the reading room all the time, can be easily done on phone now. We have definitely seen that after COVID, we have had a significant decrease in number of clinicians stopping by. It used to be we would have full teams come in to review cases, and that's becoming less and less common. So a tool like this will really kind of help you get more established with your referring providers, which is one of the biggest things that has happened in this post-COVID era. Is like where there's a big divide in the radiologists and the clinicians now, because you're not really interacting as often. So a tool like this, where you are able to interact with them, you can share case, you can show them what's going on, helps you build that relationship that can go a long way. Not surprisingly, this resulted in over a 70% burden. So the radiologist said if this tool was available, this will help them improve their workflow quite significantly in this case. So the next thing is, once you do start deploying AI, multiple AI workflow tools at scale, the question you want to answer is, are people using it? Is it actually helping? And is it safe? And that's where the governance and the analytics layer comes in. It helps you track the utilization. It helps you manage key metrics and help make clinical impact decisions. So this is really the way you operationalize AI oversight, by having these dashboards that alerts you if there's an issue. You can fix the problem early on. So it's really the main point here is that deployment without measurement is just guesswork. So this is where you are able to take out the guesswork from your analysis and know what's actually happening to your to the software that you have deployed. So here's an example of how you can use that analytical data into a system level insight. So the first graph that shows you perfusion findings by different hour. And just looking at that, you can spot patterns. You can see the peaks, you can see the gaps, you can see inconsistencies. And that can help you make decisions about things like staffing or timing of the presentations. Maybe if we have a lot more patients coming in this time, we need more staff at the time. And the real value of the real value is not the chart itself, but it's what it allows you to do. It helps you ask those critical questions, which are we delivering consistent stroke care across the day? What are the delays, and how can we improve on that? So this really connects your AI to quality improvement, where you can measure, you can identify trends, you could intervene, and then re-measure to see how well have you effectively corrected those errors. So another example is the second graph, which is the LVO suspected by patients on CTA. So one of the sites has a positive detection rate of 30%. And that in it by itself seems like they're doing the right thing, but that could also indicate they're underutilizing CTA. Maybe they need to expand their workflow or increase their CTA utilization. So it's not just AI data that's there, but it's the data that can help drive care quality across different sites. So extremely important tool for both the IT and anybody who's managing these AI tools that you have. So having access to that is quite incredible. Now that you can do quite a bit with that data. So, so far, right, we have talked about this administrative automation, like how Rapid has developed these tools to do that. And so now we'll talk about more deep clinical AI tools, how that can help improve clinical workflow. So you may know that Rapid is the gold standard in stroke, but that was just the beginning. Since then, Rapid has expanded into many other solutions. They have the largest portfolio for any neurovascular solution out there now. They're also moving into degenerative disease, MS, Alzheimer's, dementia, and through a lot of other partnerships, they have also they're able to offer solutions in oncology and orthopedics. So each of these diseases really go beyond just simple triage modules, but they can help you support the patient care, as we'll discuss. So as you see, when we talk about scalability with solutions across the healthcare, Rapid is really ahead of the curve with most FDA cleared algorithms in one unified platform. So this shows you the broad portfolio coverage that Rapid offers right now. So it's just this slide is mostly about breadth, like how AI can help across many different service lines, not just one narrow use case. So this is where you have integration of the packs, right? On one platform, you're not having to use different vendors, which means you don't have to wait 3 years for a new product to come online. And that's really about the breadth of it. So at the triage level, the value that's they're really adding is that you get the suspicion before review, so it surfaces the study that deserves detection attention sooner. It also helps with incidental findings. That's so the stuff that's easy to miss when you're moving fast. So the net effect really is that you have fewer needle in a haystack reads, and you have better prioritization, and you have a meaningful reduction in day-to-day cognitive loads as you proceed. But breadth alone isn't just the end goal. What we really need is depth, where we're able to actually measure these things, to localize it, track, and even provide 3D support for it. And this is really the next step, and that Rapid has worked on. And so think of it moving beyond just your triage and flags to really decision making support. And that's what Rapid provides. So if we just kind of look at this, just the neuro part, and within the hemorrhagic and ischemic tools, you can see how AI can contribute in multiple layers. We've already talked about the triage part of it, but AI can help you measure, it can help you localize things, it can help you track, which means it can compare to prior exams, follow longitudinally, and even do 3D measurements for you, which is for really critical for procedural planning and visualization. So this is where AI creates the biggest clinical value because accuracy and quantification guides those decisions, and the time savings that come from eliminating repeat work is really immeasurable. So one of these tools is Lumina 3D. So doing your own 3D reconstructions is very cumbersome. We saw that in our survey as well, where a lot of the people thought that doing your own 3D constructions takes too much time. But you do need 3D reconstructions for any CTA. So what I mean by that is, let's say if I'm looking at a CTA neck, the CTA neck has to has 3D reconstructions that are in the actual system. If they're not there, then you can't bill it for it as a CTA neck. If you do a CTA neck and you do not do 3D reconstructions and you don't document that in your technique, it gets down billed as a CT neck with contrast. So you take about 30 to 45% hit every single time you do a CTA and you don't do the 3D reconstructions good, it always gets down billed because that's a billing requirement for in order to bill for a CTA, you have to have 3D reconstructions, which means you have to have 3D reconstructions on this CTA. Um, anytime we do a CTA, we have to have this 3D constructions, and that has really become a big issue, especially with tech shortages, because there's major tech shortages. Whenever you do have a tech, they may be new. We have a lot of visiting techs, and they might not know how to do these 3D reconstructions, and that really results in reading delay. One of the examples that we have noticed this quite a bit in, we have been trying to figure out a solution, is trauma CTNX. So you might have seen an uptake in CTNX in trauma setting. There's a recent guideline changes. They're going back to doing a lot more of those. So pretty much any major trauma gets a CTNX. So we have seen that the head, C-spine, chest, abdomen, pelvis hits the list pretty much within minutes of them finishing the scan. But by the time the CTA neck comes across, it's been like 30 minutes. Like I've already looked at everything, and literally 30 minutes later, the CTA neck comes in. And one of the biggest delays for that, when we have looked into it, is the tech say, oh, we have to do the 3D reconstructions. So I have to wait until the patients, if you have multiple traumas, you have to get all the patients scanned, then get them out of the room, then spend time to do the 3D reconstruction, and then send it in. And that's a big pain point, right? So what if a trauma CTA neck has a dissection? I'm not getting to it until 30 minutes later, even though we scanned it a long time ago. So having that automated 3D reconstructions is extremely important to decrease the delay in it. Um, Lumina 3D does all of that for you. It does automatic 3D reconstructions within minutes, gets pushed to your packs automatically. And it does three different reconstructions. So it does the curve planar reformats, which is really what you need to calculate the percent stenosis. If you're not doing that, your percent stenosis measurements are going to be off. It provides you 3D rotational volume renderings, which our neuro IR colleagues love a lot because it helps them when they're planning. By the time they get into the case, they kind of already know the anatomy, so it's much faster for them to get into the head. And it also provides you with MIP images as well. So one of the biggest things where Lumina is really ahead of the curve is that it's actually a deep learning module. So the segmentation of the major vessels is a deep learning tool, and that really makes sure that anytime you run this, the output is actually really good. So what I mean by that is, a lot of the time when you get this CTA, there's delayed bolus timing, so you get a lot of venous contamination. A lot of these other tools that exist right now, like you're using off the scanner, they're based off of Hounsfield units. So it says if the Hounsfield unit is above this level, put it on the 3D reconstructions, which means most of the 3D reconstructions is going to have veins on the 3D reconstruction itself. Luna doesn't do that. It actually identifies the main arteries and segments those out, and then does the reconstruction. So on the 3D reconstructions that Illumina gives you, you will never have the veins on it because it has segmented out of it's purposefully segments those out of the scan. So it really results in a much better rendering, which is very reproducible. When it's reproducible, you can actually use it. It results in faster reads, and it really frees up the tech time, which means you can scan more patients, which means more volume, which means more longer days at the work. It has its ups and downs in this case. Um, so here's an example. So same patient that got scanned about 1 year apart. These are the reconstructions that were done by the tech and sent over to the PAC system. You can see like very different, right? Like very different in style. It's very hard for me to use the follow-up 3D reconstruction to make any sort of clinical decision. Just because it's so different. I don't know if the abnormality that I'm looking at is truly because of the true pathology, or is it because the tech just did the reconstruction that way? So this is the Luna 3D reconstructions that come off of it. So two different scanners, 2 different years, but the reconstruction looks very similar, which means I can actually make this part of my workflow. When I read MRA time of flights images, I'm mostly reading off of the 3D reconstructions because the 3D reconstruction gets you the answer real fast. The problem for not using the CTA reconstructions is because of this slide here, right? Like the reconstructions are always so off, so you have to use the source data every single time. But if you start to get the actual reproducible scans, then you can actually use this for clinical setting. So again, in this example, left ICA is occluded, super easy to see. Move on really quickly. They had stenosis of the right ICA, which has gotten worse on the new scan. all the clinically relevant findings that you can make off of 3D reconstructions, and you can do so confidently because it's reproducible image. So in your survey, there was a significant reduction in cognitive burden if this tool was available. So the next one, which is quite a big issue for us, is the co-registration and comparisons. We are at Barrow. We are a very large neuro ICU. We have multiple neuro ICU patients any given day, and we scan them like every single day for a variety of reasons, whether it's just to check on the hemorrhage, check on the vent size. So we get tons. Any given day, we're getting about like 50 inpatient CT scans that are required just comparing to something assessed for stability. One of the biggest problems that we run into is that the scan angles are different. These patients are intubated, so their heads are tilted, and they're all over the place. So when you're trying to decide has the vent gotten slightly bigger or not, that's honestly quite challenging. And a lot of the times we'll like report is that unchanged to minimally increase question mark ventricle caliber, but that's a big clinical decision that has to be made. If you're saying that the ventricle caliber has increased, then they're going to need a new ventriculostomy tube. So having that whenever you're doing comparison and the core registration is not there, that makes things a lot more challenging for no reason in the end, really. So there is Rapid has a solution for that. It's called Rapid Delta Fuse. So what it does is it brings the crunch scan you can see on the left side, prior scan in the middle, and then Delta Fuse image on the right side. So the very first thing it does, it co-registers. So it's at the same level. So even if there's a lot of head tilt, the scan angle is off, it will make sure you're looking at the same level. And that in itself, honestly, just look like co-registration and an alignment part of it in itself would make a huge difference. You can decrease your read time on those follow-up exams by significant, right? Like you're like, if everything is lined up, you're like, yes, stable, stable. Oh, that's bigger, that's smaller, move on. And you get to the cases much quicker. Then it also adds this delta fuse image where it's actually showing you the different changes that are happening. So you can see how on the new exam, on the current scan, the right lateral ventricle is essentially collapsed, and that actually shows you really nicely on this image in the delta fuse. So it really does a really good job of the core registration part of it itself, but also like what changes are happening. We did do a study to see how much difference does it make, and we found that using this model, you were getting through scans 36% of the time faster, and on average, that meant you're reading about 20 minutes of reading time per day, which you can spend on reading other studies. So it's really, another plus minus thing. It does increase accuracy. You are able to pick up subtle things as well. So, in addition to that, there are other tools that go very much along it, which is a hemorrhage case here. It does a really good job. It shows you the complete hemorrhage management. It's just not detecting blood, but it's really organizing information the team actually really needs. So on the left, you see it says ICH suspected, then suspected subdural hemorrhage, and then it actually gives you the midline shift if there is a true midline shift or not. So that's the information that the clinicians are really using to make their clinical decisions, and having that in one panel really helps them move things forward. So going back to the delta fuse a little bit. So on the bottom, you'll see is the current exam. That's how the scan was. So the patient's head was tilted. Head was tilted. The scan angle was different, but the core registration and the alignment makes a huge difference, right? Like it's at the same level as the prior exam, so you can make the decision whether or not things have changed or they're the same much 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 quicker, and do so with better accuracy. So, as a result, in our survey, we did find that resulted in a significant reduction in cognitive burden by almost 50%. Personally, I would have said that this would result in more than 50% cognitive burden reduction because honestly, that's like the hardest thing on those inpatients is like, is the vent slightly bigger? Is it not bigger? And if everything is lined up, making that decision is much, much easier. So, next thing we're going to talk about is the aneurysm product, which we're very excited about at Barrow. We have a very high vascular caseload. Our chief neurosurgeon, he's a vascular neurosurgeon, so we get tons of aneurysm clippings, open and endovascular treatment. So having something like this, we are very, very excited about. So you can see like this is the 3D rendering. It shows you the aneurysm. It highlights it, gives you the measurements that goes along it as well. So here's how the aneurysm tool works in practice. So let's say a patient comes to the ED with headache. This is an actual real life case that happened. So patient came to the ED with headache. CT and CTA was done, which were interpreted as normal, but it did say that there was suboptimal bolus timing. But there was a small aneurysm behind, hiding behind the clinoid. Rapid aneurysm software detected it. It alerted the neuro-IR team, neurology team, and the radiology team. So the radiologist was able to amend their initial report. Then the aneurysm tool does automated measurements. It segments out the actual aneurysm itself, gives you the various heights that the neurovascular and neurosurgeon needs to make their clinical decisions. Once they have confirmed it, this patient went to a neuro IR and had successful endovascular treatment. So it's really from the beginning of a triage where you identify it all the way to the treatment. All the tools that you need from the beginning to the end are there in one tool set. This has been studied, like to study the impact of this. A study out of Stony Brook found that 15% of the aneurysms are missed by radiology alone, and that this rapid aneurysm product detected 23% more aneurysms. Another study that was presented at an international stroke conference showed that 40% of these growing aneurysms were missed by radiologists alone, and that the detection rate of the increase in aneurysm size was at almost twice picked by the rapid mode as well. And the accurate growth tracking is extremely important. If the aneurysm is growing, that means you got to treat it. So it's in surveillance, a stable growth surgery. So that's why this part of it matters a lot. And a study out of Penn found that this resulted in better patient management. 58% of the aneurysm referrals are lost, so that you just lose them to follow up. But having this product really kind of help make sure everybody gets involved, because everybody is getting these notifications. Anybody who would be dealing with aneurysms in your institute, that resulted in 5 times more follow up with Rapid than without it. So now shifting outside of neuro for a moment, another big thing is incidental lung nodules. Probably the number one reason I didn't do body imaging. I could not look at lung nodules all day, and I think it's a perfect example of this high burden, high variability work. Um, and the work isn't just to see the nodule; you have to identify it. You have to decide if it's incidental. You have to measure it. You have to count all of them. Then you have to compare to the prior, and that's just a lot of tedious work. And as a result, the combination of these, you can see why it scored very high on the cognitive burden for radiologists, almost a score of 8. So this is exactly where AI can be useful. So it can detect for you, it can measure for you, so you can then make the clinical decision what should be done with the nodule itself. So here's the how the lung nodule module works as. It actually does a vessel suppression sequence, so it will suppress out all the vessels, because that's one of the biggest pitfalls of these lung nodule modules have been that they will it detects a vessel and calls it an aneurysm. So the very first thing, by suppressing other vessels, you decrease your false positive rate. Once it's done, it co-registers with the CT, source CT, and it will help identify and characterize and even measure abnormalities. So so one of the things, if you see in the left hilar region, there's a nodule. That is something I'm always worried about. I'm going to miss because of all the main vessels there. So that vessel suppression in itself does a really easy makes it really easy for you to identify those. Um, More importantly, what it does, it will once you do the measurement, it will integrate into the report. So it can actually even redo the measurements on its own and compare to the prior and show if there's an increase or not. And again, all of those measurements go directly into the radiology report, so you don't have to worry about doing that. So you're mostly double checking, making sure that it did the right thing, and what action should be next. And so that's really where radiologists should be now. It's more clinical decision making rather than doing this tedious task work. In our survey, we found that this resulted in a significant decrease. I would have given an even higher score for how much it will help me in my workflow. In its Other studies have found that you have far fewer missed nodules, and you read those scans much quicker too. Another tool is the rapid aortic module that's been coming online. It can identify aneurysms across the network on non-contrast CT, CTA, just contrast enhanced CT, and it detects quite a bit more. And this is how the outputs looks like. And so here's a little bit more. So this is your CTA. You see there's a dissection going down the aorta. Here's your Pro Navigator. You can see all the major measurements that vascular surgery cares about when they're looking at this. And all of these measurements are done along a center line. That's the biggest thing. So if you're just doing measurements on your own on axial, those measurements might be off because you're not in the center line technology. You're not using the center line to get to the middle of the actual the circle itself. So that's exactly what it does. It uses the center line technology to help give you the best measurement that you need for the clinical decision making. Does the 3D rendering for you so you can kind of see what it looks like, and even gives you this curved planary formats that helps you track the abnormality a little bit better. And it will also give you this straight view, which I really like. Kind of straightens out the entire aorta and see everything one place. Lastly, it will does comparison for you. So it will bring in the new, bring in the prior. Measurements are there, shows you the change, and that gets imported into your report. So honestly, a lot of tedious work. These studies are not difficult to read. The tedious part always is how do you do these measurements? You want to do it accurately. You're trying to get the scan angle right, and it kind of takes out a lot of that extra tedious work for you. So these are the results of the survey, some of which we have already discussed, but AI tools overall can reduce 60% of the cognitive burden across the board. So what we really talk about today is a simple playbook, right? So target the parts of workflow that reliably creates burden, and we can reduce them in a way radiologists will actually adopt and appreciate. So across the examples, stroke, perfusion, hemorrhage, there's aneurysms. A lot of those things have a lot of similar things that kind of tidy them down. That being a lot of the tedious work. So the burden really isn't just the interpretation, but the prioritization, this context switching, the measurements. And when AI is delivered as a separate destination, it can add work to that work that's already there. But once you embed it into the actual workflow, it saves time and it improves care. And which means get through the studies faster, fewer misses, and less burnout overall. So I showed this slide at the beginning of the talk about the various challenges that exist in radiology workflow and how there are different tools that are available in one platform. And I think that's the key. It's one platform, which means once you're onboarded, you just add on the solution. So you're not waiting several years for it to come online, especially if you're part of these big hospital corporations now. And really kind of helps you streamline the care that patients need in all cutting edge technology. So to close, AI in radiology is moving fast, but the success metric is still simple. Does it help us take care of the patients? Is it reliable, and is it scalable? And that's where really Rapid comes in. We discussed numerous workflow problems and how Rapid has the ability to provide those solutions from workflow from end to end, and do so in an effective manner in a single platform. While Rapid was just a neuro AI company in 2018, today is much more than that, and I think that's all the tools that they have provided us with. So thank you so much for your time.